Dear friends, chronic otitis media is today's topic, and this is a very hot topic for many examinations. It is from the Department of Otorhinolaryngology. I am Dr. Parvez Ahmad Reshi. Dear friends, you can see in this diagram the margins of the perforation and the discharge inside the perforation in the middle layer and the cholesteatoma here. It can be easily seen. This is the otoscopic finding in a patient who had complicated type of chronic suppurative otitis media. So in this presentation we will discuss about the types of CSOM, and we will discuss the treatment, and we will discuss different things in minor detail. What is the definition of otitis media? Chronic otitis media, simply remember, it is unresolved inflammatory process. Unresolved inflammatory process of what? Of middle ear cleft, or it is unresolved inflammatory process of middle ear and mastoid associated with tympanic membrane, perforation, otorrhea, and hearing loss. Paul is associated with COM. Who is Paul? It is perforation, it is otorrhea, and it is loss, hearing loss. It is Paul. Perforation, otorrhea, and loss of hearing. It is associated with chronic otitis media. Unresolved inflammatory process of middle layer and mastoid associated with tympanic membrane perforation. Guys, there are different definitions of this process of chronic otitis media. Some say it is unresolved infective process. Some books say it is unresolved inflammatory process. We'll come to another definition in the following slides, in the slides which will follow, but for now let us remember it is unresolved inflammatory process of middle layer and mastoid associated with tympanic membrane perforation, otorrhea, and hearing loss. What is the etiology? We say that it is the beginning of etiology. We say unresolved middle layer infection, uncomplicated inflammatory process of middle layer may evolve over time and to produce persistent effusion and irreversible mucosal change. Fluid contains enzymes, and those enzymes alter the mucosal lining of middle layer. So it results in collapse and chronic perforation. There is fluid in the middle layer, and that fluid contains enzymes. Those enzymes change the mucosal lining of the middle layer, and that change results in the collapse and chronic perforation. Third is obstruction of narrow communication between antrum and etic. There are two A's. One is antrum, another etic. And then there is a communication between the two, and that is aetitus. So when this aetitus is blocked, so there is narrow communication between this, and it may result in the formation of cholesteatoma, in the formation of chronic suppurative otitis media. So this is unresolved middle layer infection. So what will happen in unresolved middle layer infection? There is inflammatory process, there is accumulation of fluid, and there is obstruction of aetitus. Look at this picture. Here you can see discharge, white purulent discharge coming out of external auditory canal, and this is a feature of an associated feature of complicated chronic suppurative otitis media. Etiology continued. We have dysfunction of eustachian tube may result in chronic suppurative otitis media, chronic inflammation in nose or pharynx. Remember, nose and pharynx, they are closely associated with middle layer through eustachian tube, and so if there is chronic inflammation in nose and pharynx, and it may spread to eustachian tube, and it may spread to the middle layer, and it may lead to CSOM. Dysfunction of immune system if a person is immunocompromised, and then it is very much possible that he may get small infections from friendly bacteria. He may get infections in the middle layer, and then it may be difficult for the body to remove that infection from middle layer. Let's go here. There's the inflammation of the middle layer, and then there's mucosal edema and mucosal ulceration and epithelial breakdown. So then we can move here, and you see that attempt at healing granulation tissue formation. And so then there is irritation of the middle layer. So how it starts, that suppose there is some irritation in the middle layer, then there is inflammation of the middle layer. So always remember the word inflammation is the key word in CSOM. So there is inflammation, there is mucosal edema. So inflammation leads to edema, and edema leads to ulceration and epithelial breakdown. So there is inflammation, then there is edema, then there is ulceration here, and after that there is healing, attempt to healing. So granulation tissue formation is a part of healing. When granulation tissue is formed, there is again irritation of the middle layer. So it is a circular process. There is irritation, there is inflammation, there is edema, there is ulceration, there is healing. Again there is irritation, and this circle goes on and on. What is the pathology of CSOM? Middle layer mucosa is lined by secretory epithelium forming a gland-like structure. So middle layer, we can say, is a gland-like structure because it's lined by secretory epithelium. Hyalinization or tympanosclerosis may occur, and we have how hyalinization or how tympanosclerosis takes place is the healing response. It occurs during quiescent period. So we will tell you later on that there are 4 stages of safe type of otitis media, and hyalinization and tympanosclerosis takes place in the quiescent period when there is no disease, when disease is silent. It is formed by fused collagenous fibers. So then it is hardened by deposition of calcium and phosphate crystals. So there is conductive hearing loss is associated with masses restricting ossicular mobility. So as we know, there is hyalinization, and hyalinization is formed by fused collagen fibers. It is hardened by deposition of calcium. There is collagenous fibers, they fuse, they form a cartilaginous type of structure, a hyalinization of the middle layer, and then it's hardened by deposition of calcium. Conductive hearing loss is associated with masses restricting ossicular mobility. So when there is hyalinization, there is limited mobility of the ossicular chain, and so it may lead to conductive hearing loss. Pathology continued. Ossicular erosion is frequent in COM. Infection process, necrosis following vascular thrombosis. It is most commonly affects the lenticular process of the incus and head of stapes. What happens? Ossicular erosion is frequent in COM, and what leads to ossicular erosion is the infection process, necrosis following vascular thrombosis. If there is vascular thrombosis, so there is necrosis of the ossicles. There is infection of the ossicles. It most commonly affects the ventricular process of the incus and head of stapes. So if there's a question, cholesterol granulomas, how cholesterol granulomas are formed, and then we can say presence of yellowish masses surrounded by granulation tissue, edematous mucosa, and fibrous tissue. So cholesterol granulomas, what are cholesterol granulomas? We will say that there are presence of yellowish masses. We can find presence of yellowish mosses. These are called cholesterol granulomas, and these yellowish mosses are surrounded by granulation tissue, edematous mucosa, and fibrous tissue. So it contains many cholesterol crystals and foreign body giant cells. So we have cholesterol granulomas. They are yellowish masses. So definition is these are yellowish masses which are surrounded by granulation tissue, edematous mucosa, and fibrous tissue. Granulation tissue, edematous mucosa, and fibrous tissue. It contains many cholesterol crystals and foreign body giant cells. Remember how the CSOM begins. We can go here. It is acute otitis media. CSOM begins very early as acute otitis media. If it is resolved, if it is treated in a good way, there is resolution of acute otitis media. But if there is persistent effusion, if there is fluid in the middle layer, there is persistent effusion in the middle layer, then if suppose that fluid resolves, nothing further will happen. But if this persistent effusion will lead to chronic otitis media with effusion, then again it may resolve at this level also, and there may be sequel of this, or there may be perforation. If there is perforation, it will lead to CSOM. Again we have acute perforation due to, then plus we have otorrhea. If there is resolution plus healing, nothing will happen. And there is resolution or chronic perforation, then dry and inactive stage. It will become dry and then it will go into inactive stage. Then if there is a recurrent otorrhea, it will again lead to CSOM. Otorrhea, acute perforation and otorrhea, it may directly lead to CSOM, or it may lead to suppurative complications and non-suppurative complications. We have suppurative complications and non-suppurative complications of CSOM. Then we have, what is the definition? Again, as I told you that CSOM has different definitions, and one of the definitions is it is defined as chronic infection of middle layer mucosa lining the middle layer cleft. So what is CSOM? It is defined as chronic infection of middle layer mucosa lining the middle layer cleft. The duration of infection should be more than 3 weeks. Middle layer cleft includes eustachian tube, middle layer proper, and the mastoid air cell system. So three things. Middle layer cleft includes eustachian tube, middle layer proper, and mastoid air cell system. CSOM type. We have safe type, it is tubotympanic disease, and we have unsafe type, it is etiology disease. Tubotympanic disease is safe, profuse or mucoid colorless discharge is there. We have central perforation, we have no cholesteatoma, we have no granulations, rare or no complications, and mild conductive hearing loss. So again, tubotympanic type, it is safe, profuse or mucoid colorless discharge, central perforation, no cholesteatoma, no granulations, rare or no complications, and mild conductive hearing loss. Otherwise, in etiology type, here etiology type we have unsafe, it is also called unsafe. The discharge is scanty, purulent, and foul smelling. So it is central perforation, not central perforation. Perforation may be in the atic, or marginal perforation. There is formation of cholesteatoma. Cholesteatoma is present in unsafe etiology disease. Uncommon, no, not uncommon. There is common granulations are formed. Common granulation tissues are formed. common complications are there. There are common complications. There is CHL or mixed hearing loss. CHL or mixed hearing loss. Then we have tubotympanic disease. Further we elaborate tubotympanic disease. It is also called as safe air, and we have it does not cause any serious complications, and infection limited to anterior inferior part of middle ear cleft, associated with central perforation as already discussed. Why is tubotympanic disease safe? No risk of bone erosion. Not known to cause intracranial complications. Discharge from middle ear flows freely through the perforation in the pars tensa. Usually the perforation of pars tensa is surrounded by a rim of intact drum. The annulus is intact. Microbiology. Gram-negative bacilli has been commonly isolated. Pseudomonas aeruginosa, E. coli, B. proteus. It is PEP. We have Pseudomonas aeruginosa, E. coli, and P for proteus, Bacillus proteus. These organisms are not commonly found in the respiratory tract. These organisms are commonly found in the skin of external canal. Stages of tubotympanic disease. Acute stage, inactive, quiescent, healed. Acute, inactive, quiescent, healed. Now we come to etico-enteral type of CSOM. It's also known as CSOM with cholesteatoma. So this is the unsafe type of CSOM. Cholesteatoma. Cholesteatoma is defined as cystic. It is cyst-like, expanding lesion of temporal bone, lined by stratified epithelium and containing desequamated keratin and purulent material. So what is cholesteatoma? A lesion of which bone? Cholesteatoma is a lesion of temporal bone. Is it expanding or non-expanding lesion? It is expanding lesion. Is it cyst-like or not like a cyst? It is cyst-like expanding lesion of which bone? Temporal bone. Is it lined by columnar or other epithelium? It is lined by stratified epithelium. What does it contain? It contains desequamated keratin and purulent material. So, in short, cholesteatoma is a cyst-like, it is an expanding lesion of temporal bone. It is lined by stratified epithelium. It contains desequamated keratin and purulent material. So you have to remember, it is an expanding lesion. It is a cyst-like lesion of temporal bone. It is lined by stratified epithelium. It contains desequamated keratin. It contains purulent material, right? So all these things, when you remember all these things, then only. So what is the classification of cholesteatoma? How do we classify cholesteatoma? So it may be congenital cholesteatoma, that which is present in the mother's womb soon after birth. You have cholesteatoma, but it is diagnosed later in your life. Acute cholesteatoma, so that which is acute secondary to infection and inflammation, and then first it may be safe type, then it may go to unsafe type, and then that is the another type. So it is two types of cholesteatoma, congenital and acute. So what is the pathology of cholesteatoma? Mechanism of mucosal transformation and epithelial ingrowth have been the focal point of cholesteatoma. So you are standing in exam. Examiner says how cholesteatoma is formed. Say mucosal transformation. And epithelial ingrowth. Say these two words. Mechanics of mucosal transformation and epithelial ingrowth have been the focal point of cholesteatoma. So what is the focal point of cholesteatoma? How you define it in one word, the pathology? Sir, it is the mucosal transformation and epithelial ingrowth. This is the answer. Remember the word epithelial ingrowth and mucosal transformation. This is the focal point of cholesteatoma. What is pocket retraction? So the second is pocket retraction. It may be due to what is the cause behind pocket retraction. It is due to dysfunction of eustachian tube. When we have dysfunction of eustachian tube, we get pocket retraction. That is a cause of cholesteatoma. Epithelial migration. So another theory. The edge of peripheral perforation. So we have peripheral perforation, and then there is epithelial migration from the edge of peripheral perforation, and it goes into the mastoid cavity and inside of the ear, and it causes what it causes? It causes formation of cholesteatoma. Inward growth of surface epithelium follows papillary proliferation of the germinal layer of Paris flaccida. So we have Paris flaccida. Inward growth of surface epithelium follows papillary proliferation of germinative layer of Paris flaccida. So we have Paris flaccida, and epithelium from Paris flaccida, from the germinal layer of Paris flaccida, goes in and forms cholesteatoma. So this is a cholesteatoma. You can see here, this is this white cheesy material containing keratin debris and keratin material, and this is metaplasia from pseudostratified ciliated columnar epithelium. So metaplasia, we have pseudostratified ciliated columnar epithelium, and that metaplasia occurs and there is formation. So what is pathogenesis of congenital cholesteatoma? So what we discussed till now, that was the pathogenesis and the pathology of acute cholesteatoma. Now what is the pathogenesis of congenital cholesteatoma? So pathogenesis of congenital cholesteatoma is ectodermal epithelial in the proximity of geniculate ganglion medial to the neck of the malleus. So ectodermal epithelial in the proximity of geniculate ganglion medial to the neck of malleus. We have that medial to the neck of malleus, we have geniculate ganglion, and in the vicinity, in the proximity of the geniculate ganglion, there is ectodermal epithelial invasion, ectodermal epithelial origin of congenital cholesteatoma. Diagnostic criteria. What is diagnostic criteria? That is patient without previous history of ear disease. Patient has no previous history of ear disease with normal intact TM. So the temporal bone pneumatization should be normal. So the pneumatization has to be normal because there was no disease. So the pneumatization has to be normal. And then we have clinical presentation. How the congenital cholesteatoma presents. Autoria. So this is the presentation of cholesteatoma in general. Mostly when there is autoria, we talk about autoria, it is the presentation of acute cholesteatoma. Now we are talking about acute cholesteatoma. Autoria malodorous associated with cholesteatoma. So the air discharge is associated with bad smell. Hearing loss. Air conduction threshold is within 40 decibel, means tympanic membrane perforation with intact oscular chain. If there is air conduction threshold 40 decibel, means tympanic membrane perforation with intact oscular chain. If air-bone gap is more than 40 decibel, it is associated with discontinuity of oscular chain. So if hearing loss is 40 decibel air-bone gap, so 40 decibel associated with discontinuity of oscular chain, and if it is less than 40 decibel, it means that there is perforation with intact oscular chain. Now, clinical presentation, what are the physical findings? Defect in the pars, tensor of tympanic membrane or the pars, flaccida or both. Atelectatic lesion in the tensor or flaccida pars. So we have squamous epithelial invasion may invade middle layer, and we have granulomatous polyps, tympanosclerotic clogs in the middle layer. So clinical presentation and physical findings: defect in the pars, tensor of tympanic membrane or pars, flaccida or both. Atelectatic lesion in the tensor or flaccida pars. Atelectatic lesion in the tensor or flaccida or pars flaccida. Squamous epithelial invasion may invade middle layer. Granulomas, polyps, tympanosclerotic clogs in middle layer. These may be the clinical presentations, physical findings in the patient. So we have here radiographic evaluation indications for image study when we will prescribe in a patient who has ear disease, when we will go for CT. Uncontrollable oral discharge, when the discharge is not under control, patient comes to you 4 times, 5 times, 6 times, 6 months, or long duration, gives a history of 3 years, 2 years, and since childhood like that, and then you give antibiotic for 5 weeks and then you go for CT scan. Complications such as facial paralysis. So patient comes with facial paralysis and labyrinthitis. So facial paralysis is a indication for radiographic evaluation of the patient. So if a patient has facial paralysis, go for radiographic evaluation. When central nervous system involvement is suspected, MRI should be considered. If the central nervous system, you consider the involvement of central nervous system, you go for MRI should be considered. Coronal CT scan is preferred. So you go for coronal and sagittal sections of CT scan, or go for coronal CT scan. It is preferred over other modalities of CT scan. Differential diagnosis. Tuberculous otitis media may be one of the differential diagnosis. So you are standing in exam and the patient and the examiner asks, what is the differential diagnosis of CSOM? You keep in mind tuberculous otitis media. Hematogenous route, it may spread, that tuberculous otitis media, it may spread through the hematogenous route. And multiple perforations and fetid. So multiple perforations and fetid. Creamy oral discharge. If there is creamy oral discharge, you suspect tuberculosis. If there are multiple perforations, you suspect tuberculosis, and it comes through the hematogenous route here. And active pulmonary disease, multiple antituberculous agents. And if there is history of multiple antitubercular agent intake of ATT intake of for there is active pulmonary disease, there is creamy oral discharge, there is multiple perforations, and there is every suspicion of hematogenous route from acute pulmonary disease, and that may lead to tuberculous otitis media. And the tuberculous otitis media may be one of the differential diagnosis of the CSOM, but it is not so common, it is very rare. So don't come to this point in the beginning say it is tuberculosis otitis media. No, and say first what are the common causes. Differential diagnosis, middle layer carcinoma. This is the second grave thing. Middle layer carcinoma may be the second differential diagnosis of what? Of CSOM with cholesteatoma. Cholesteatoma. So the second differential diagnosis, middle layer carcinoma. Middle age patient. If the patient is middle age, and so we may have middle layer carcinoma in these patients. Long-term otorrhea with blood, and if there is otorrhea with blood, you consider that it may be middle layer carcinoma, and don't think that it's only it is the differential. It comes in the middle layer carcinoma comes in the differential diagnosis of long-term otorrhea. Cholesteatoma. Middle age patient is middle age, don't suspect middle layer carcinoma in a small baby, small child, or in a age 30, age should be middle-aged people. Okay. Then otalgia, if there is pain. Usually cholesteatoma, no pain, but if there is pain, then this may be miliary carcinoma. Neoplasm in tympanum. If there is neoplasm in tympanum, and we suspect that there's a neoplasm in tympanum, and then already patient had a tympanum neoplasm, and then it may be the invasion, it may go to the middle layer, and that we may suspect cholesteatoma, but it may not be the cholesteatoma, it may be middle layer carcinoma secondary to neoplasm in tympanum. It may be this, it may supralocally neoplasm in tympanum, and it may appear just like a cholesteatoma lesion in the middle layer. CT scan showed temporal bone destruction. If you can find temporal bone destruction in the CT scan, you think it is middle layer carcinoma. And no, you say that patient is middle-aged, long-term otalgia, neoplasm in tympanum, CT scan showed temporal bone destruction. These are features of middle layer carcinoma, and no, don't go with the cholesteatoma, because there is pain, there was already a neoplasm in tympanum. This is a middle-aged person. There is oturia with blood. Management, medical treatment of cholesteatoma. What is the management? So first, goals: infection control, stabilization of process, prevention of irreversible damage, and development of serious complications. Goals. So we prevent we what are the goals of medical management? Goal is infection control. We go for infection control, stabilization of process, and prevent irreversible damage, development of serious complications. We don't want serious complications to develop. We want the process to stabilize. We want to control the infection. We give 3% H2O2, clears up pus. Then antibiotic air drops is used. Give 3% H2O2, it clears up pus. Then antibiotic air drops is used. With the decrease of pus, 3% boric acid glycerin, 3% boric alcohol can be used. No aminoglycoside airdrops. Don't give aminoglycoside airdrops. Remember, aminoglycosides have 3 side effects. One is neurotoxicity, ototoxicity, and neuromuscular blockade. These are the complications of aminoglycosides, and this is the these are the 3 side effects, and they may damage the nerves supplying the air, and they may cause ototoxicity, and may lead to sensorineural hearing loss, and other that they may damage the ear. No powders containing antibiotic and erosion ear drugs. Don't give toxic ototoxic drugs. What are the management surgery? Management continued, and we have now surgical management. What is the goal? Safe air, dry air, hearing air. Safe dry hearing, safe dry hearing, safe dry hearing. So safe dry hearing is the goal of surgery. A classification of surgery, we usually classify them as per Wolstein and other thing, and is that we have myringoplasty, tympanoplasty with mastoidectomy. These are the 3 surgeries which we can go for. Thank you very much. Please like and subscribe, and please visit my website and and try to do this. Try to like my videos and find my other channels. I have few channels and I have few websites, and please like and subscribe. You will find the link below. Thank you very much.